Hi, my name is Joe Kowalski. I'm an orthopedic spine surgeon at UBMD Orthopedics and Sports Medicine. The purpose of this video is to demonstrate a physical exam for the lumbar spine. It's not all-inclusive, but should serve as a template for further exams. The exam can be tailored and customized to any clinical environment, be it an office setting, be it a playing field, a trainer's room, or a trauma pod in the emergency department. There are 5 major components to any physical exam of any body part or region. The first one being inspection, then palpation, range of motion, neurologic exam, and then special maneuvers. Inspection starts from the first moment you can visualize the patient. Typically the patient's in the examination room, already in a gown, and the history and chief complaint have been obtained. The physical exam is an interactive and dynamic act. It's important to get as much out of the physical exam and encounter as possible. So commonly, you're asking the patient questions and feedback during the encounter. I typically enter the room and introduce myself. I like to have the patient then stand up and so I can better inspect them. Come down here. So the first thing I'll do is do an inspection. It's important to have the person properly gowned or in proper attire. In the back scenario, I'll have you turn around. It's important to visualize the spine, looking for any sense of asymmetry, looking at midline defects or hairy patches or surgical scars or other deformities. The first thing I'll have the patient do is, keeping their hands down straight, is bend forward to touch your toes as best as possible, and we're looking for asymmetry in the ribs, underlying scoliosis, midline defects, or step-offs. And then the patient will stand back upright erect and extend themselves beyond neutral once again also. So inspection, once again looking for symmetry in the torso, in the gluteal musculature, and lower extremities. It's very important to see the lower extremities, looking for atrophy, muscle bulk, fasciculations, skin changes, and so on in the lower extremities. After inspection, we'll then do palpation. I'll have the patient do is turn around. And then the patient, I'll ask them where their chief complaint is. They may point with one finger to one area. They may point with a hand to an area, or may point in a direction how pain or symptoms radiate to one body part or another. I will then further identify the area by palpating manually. Once again, you're trying to gain the patient's confidence and trust so that you can get the best information out of your exam. If you go to the most tender part first, you're not going to be able to get a full appreciation of their symptoms. After that, I will then have the patient perform a range of motion examination. So turn around, kind of face that way. And I want you to do this with your knees straight and arms straight. Flex forward and try and touch your toes as best as you can. Keep on going. And there's different ways of measuring. You can take a ruler and look at the fingertip distance to the floor. You can measure with a tape measure, excursion in the trunk, and you can straighten back up now. And you can do maximum excursion from the baseline. With the patient then, once again, facing that way, I'm going to have you, with keeping your arms straight, reach down your leg and see how far you can side bend. Just to the left, and now go to the right. Looking for pain or limitation, and you can relax. And once again, you can simply measure the distance from your fingertips to the floor, or use their shin and leg as a reference, being the knee, the mid shin, or distal shin. And that's range of motion. I also like to examine the gait. So the patient, I'll have them turn once again this way and back up this way a little bit. Give us some space. I want you to simply just to walk across the room looking at their gait. It should be reciprocal, in tandem, heel, toe, heel, toe. Now I'll have the patient stand on their tippy toes and toe walk across the room and relax now. Good. That's checking the plantar flexion and also a degree of stability. Coming back on this side, I'll then have you bring your toes up in the air and walk with your heels across the room. Once again, looking for coordination and also the strength of the tibialis anterior and extensions of the toes. Now we'll have you have a seat right up on top here. So we did the inspection, we did the palpation, we did the range of motion, and we kind of started part of the motor exam. In the neurologic exam, there are 3 main components. We have the motor strength testing, reflexes, and sensation. In motor strength testing in the upper extremities, I like to go from top down. In the lower extremities, I'll kind of go the opposite way. Having them heel walk and toe walk is a good way to get S1 and L5. In the seated position, I'll have them start by first doing a plantar flexion, so push down real strong, and that's the plantar flexion, S1. Good. Now cock up your toes really strong, really strong, really strong. The EHL, the long toe extensor, that's L5, and the tibialis anterior is L4. Straighten that leg out, also real strong. Hold this knee out, straighten it right out. Oh. Good, hold it there strong. This is another way of testing L4, actually L2, 3, and 4 for the quadriceps muscle. You can relax. Once again, look side to side. If it's weaker on one side or the other side, you can further investigate with more detailed examination. So motor strength, S1, L5, L4, those are the major neurologic structures in the lower extremities. When it comes to reflexes, once again, we go to the Achilles reflex, which is S1. So we'll have the patient in the seated position. You can look for a flexion of the foot. I'll also look for Babinski sign or evidence of clonus, suggesting an upper motor neuron lesion. Motor strength testing, reflexes, and now sensation. And once again, go to my pocket pinwheel, which is nice. We can evaluate L3 goes across the knee symmetrically. L4 goes to the anterior shin on the tibialis anterior to the instep bilaterally. L5 goes to the first dorsal web space, and S1 to the outside of the foot and lateral ankle. So we briefly covered L3 across the knee, L4 to the instep, L5 to the first dorsal web space, S1 to the lateral foot. And now we do provocative maneuvers. In the lumbar spine, we're worried about radiculopathy and sciatica. Sciatica is that irritation of the sciatic nerve, the different components. It's difficult, if not impossible, to irritate that part of the sciatic nerve that only goes to the back. People with true sciatica will have radiation of pain from the low back to their thigh and down below the knee. So a positive straight leg raising typically has to have symptoms that radiate below the knee. The symptom may be pain, numbness, paresthesias, or weakness. Typically, I'll have the patient themselves, first of all, straighten their leg out in the seated position. A patient with true sciatica will not voluntarily stretch their sciatic nerve. They'll either keep their knee bent or they'll lean back onto their hands in a tripod position, taking the pressure off their sciatic nerve. You can relax there. So that's very helpful to do that maneuver in the seated position. Also, while you're down here, you can look for peripheral pulses and skin integrity, looking for other metabolic and other underlying medical conditions. And I'll have the patient now position themselves supine in the examination table. We once again also want to examine the adjacent areas when it comes to examining the spine. The spine and hip can have overlapping symptoms, and therefore it's important to identify what may be the cause of the primary symptoms. A simple thing to do in the seated supine position is with the patient relax, is internally and externally rotate the thighs. This is motion through the hip joint, and people with true hip pathology will have discomfort into their groin. Another maneuver would be a Patrick Faber's test, where you have the person in a figure 4 position, where they flex, abduct, and externally rotate their hip. People with very stiff hip won't get this far or have significant groin pain. And then you have them relax. When it comes to straight leg raising in the supine position, I try to have the patient perform that maneuver first themselves. So keeping your knee straight, can you bring your right leg up in the air? A patient with true sciatica will not go beyond 30 to 60 degrees without wanting to stop because of irritation of their sciatic nerve. You can do it passively by having them relax, keeping the knee straight, and if they have symptoms that once again radiate down below the knee, that's consistent with sciatica and radiculopathy. You can then bend the knee a little bit, taking tension off, and then dorsiflex the foot, which will reproduce our symptoms once again, and that would cause symptoms with sciatica. There's another test called a positive cross straight leg raising test. If I raise the right leg and the patient has symptoms down their left leg, once again below the knee, that's suggestive of a large disc herniation in the posterior medial area on the contralateral side. So some people believe a cross straight leg raising test is pathognomonic for a large posterior medial disc herniation on the contralateral side. You can relax. And those are the major components to a lumbar physical exam. There are a variety of other maneuvers I haven't discussed and some findings and features. You can look them up on your studies. And so I hope this has been helpful to evaluate lumbar spine and hip pathology. Have a good day.